So I decided to add this extra, just supplementary presentation that I had and updated a little bit. I recorded it a while ago, but it does a good job of giving some of the background information that we need to talk about before we get into the modality. So if you don't understand these sort of background issues, then you may be a little bit behind in the modalities application portion because all of these things apply to all of the modalities. So we don't talk about them for each modality, but we're just going to talk about them here.
So, we've talked about the legal considerations in patient care before and how part of our responsibility in designing our treatment programs is to know what our rules are from governing organizations. Understanding that athletic training is a licensed and protected field in the vast majority of states, California being the exception. There has to be some sort of at least registration or licensing, and these licensing describe the the rules within that state. In addition, this legal responsibility really takes into play the components necessary to avoid litigation as well as be proper. And the big thing that we will see as we go through is this contraindications right here. Right, contraindications indicate an area that we should absolutely not perform a therapeutic modality treatment on. So the only problem with that is the contraindication list is not set in stone. As we'll see when we go through the different modalities, there are a lot of different contraindications listed. Some are listed as precautions, and then some are listed as contraindications in some situations, but then routinely avoided. Also, the problem comes that there's a lot of contraindications that have just made their way into general understanding that really aren't contraindications. We talk about the crossing the spine, with IFC being one of the big ones that I just have not been able to find a reference to as far as crossing the spine. And when you look at it from a physiological standpoint, the penetration depth of IFC is not anywhere near the level it would need to be to stimulate the nerves, as well as electrical stimulation of nerves is not a big deal. In fact, that's what we're doing. So if for some reason you were to stimulate the spinal cord, you would get the unusual sensations all the way through, but the chance of damage is not very great. Lastly, as we go through in these legal considerations that we talked about before, the maintenance requirements and safety requirements of the device really get into play. So we have to consider those within our treatment protocol. Scope of practice then gets into the actual legal boundaries set by the state. Medicine and athletic training, as well as physical therapy or any other of the allied healthcare professions, are all state-run policies. And so each state has their legal boundaries regarding what clinicians may be able to perform, and it's not always the same. Nevertheless, a lot of states in their rules associated with that have left a lot of gray area associated with what can and cannot be accomplished. And we talked a little bit about this last time with the idea of the expanding scope of practice for the athletic trainer to include things like suturing and administering IVs that go into play, and the expansion of those into the scope of practice of athletic trainers as we train them individually to be able to do those skills. Most states allow that expansion. In addition, when you go through and get advanced training in certain modalities or rehabilitation skills, then those can become part of your scope of practice. One of the other interesting components is the idea of self-taught skills in areas in which specialized certifications exist. For example, like that instrument-assisted soft tissue mobilization or the scraping technique that we do on a regular basis. There are a lot of different certifications associated with that technique, and so whether or not you are certified or not in that could comprise some sort of legal issues. Now, if you're doing it correctly, you're usually okay with those sorts of things. However, it's not always that simple. When litigation actually comes to play in this, what often occurs, and the requirement is that they show that there was a deviation from the norm regarding the application. So most of the time you're okay doing what everyone else does, and so that's, you know, a good safety net with that. But if you ever have any questions on things, the NATA position statements tend to become the overriding policy statement for that. But then you also have your institutional policies and procedures manual, and failure to comply with your own institutional policies and procedures manual can get you in trouble. And we'll talk more about policies and procedures manuals here in a second. Another thing to consider as we go through is the idea that some things are required to have a prescription to do. Each in therapy can be one of those as well, but state by state there are some laws associated with different things. One of the biggest ones that we see on a regular basis in the athletic training world is the use of iontophoresis and dexamethasone. Dexamethasone is an anti-inflammatory that you use in the iontophoresis treatment. However, dexamethasone is a prescription medication, and each individual receiving an iontophoresis treatment should have their own prescription for that. In reality, that doesn't always be the case, but from a strictly legal and point of view, it really should be. So when we look at these state regulations, and it's not always easy to understand, and it's not just the regulation itself, it's all the rules that then are interpreted from that. So when you look at this, you really should spend some time studying each one of your state's practice act that you practice in, because it's not only the regulating the practice, but also making sure that you don't infringe upon the practice of other disciplines defined by that state. And so some states have specific rules. One of the big ones that we see is joint mobilizations and manipulations. Whether or not that's part of it, the expansion of the skills of the athletic trainer and the domains of the athletic trainer for the BOC test through CATIE, or as that will follow the CATIE's expansion of the educational disciplines, will include these joint manipulations for the spine. But remember, the BOC for the athletic trainer exam really only assesses the preparation. So that's why we spend a lot of time in this course, as well as other places, making sure that we are getting what we need. I don't think we're recording. All right, the other aspect here that we've got to consider as we go through is, remember, the state regulation of athletic training. It's that State Board of Medicine. And as these go, it is worth time to spend some time studying the Practice Act of the state that you go through, specifically with regards to the therapeutic modalities being one of the components, but it was components most often associated with litigation, but also the advanced procedures, things like joint mobilizations, as the KD seeks to continue to expand the educational domains of the athletic trainer. One of those that is part of the expansion talk is the manipulation of the spine.
So I used to have some of these questions built into the presentation, and so I've done these slightly differently, but I left them in this presentation because I used the questions as a way of teaching with that. And so what you'll see here coming up momentarily is I'll ask a question, and then there'll be... So I used to have some of these questions built into the presentation, and so I've done these slightly differently, but I left them in this presentation because I used the questions as a way of teaching with that. And so what you'll see here coming up momentarily is I'll ask a question, and then there'll be a little bit of time for you to think about the answer, and then I will tell you the answer and talk about that.
One of those questions that seems to always come up here and there, and so it's worth noting here as well. What is the highest form of state regulation? A, licensure, B, certification, C, registration, or D, exemption? And it is licensure. Each one, it's actually in order there. Licensure has specific requirements as well as a practice act. Some states have certification, which basically means that you have to be or you have to get certified within that state, and there are different rules associated with what needs to be for certification, but does not have a practice act. Registration is pretty much just a tax, which says that, you know, in order to practice within a field, you have to register with the State Board of Medicine, but there are very few, if any, restrictions associated with practice. And then the exemption is simply a law saying that these individuals are exempt from infringing on other practice acts within their domain, but provides no real quality control. So if we had to boil down the administrative considerations and legal components as far as what everything should be regarding the treatment planning, this is probably your most important slide right here. The idea of informed consent. And what informed consent basically is the idea that, with the exception of emergencies, patients have to be informed and must grant their consent to be treated. There's a lot of protection on the idea that our individuals are over 18, so they're allowed to give their own consent, as well as the fact that unless you're holding down individuals and forcing them to do the treatment, which isn't good, obviously, there is some implied consent within that, but it really isn't as strong as it really should be, and there are specific components. So start off with the question here that goes through before we talk about it, like we often do. Of the following, which is or are components of informed consent? 1. An explanation of the diagnosis or findings of physical examination. 2. An explanation of the risks and benefits of recommended treatment. 3. Assurance that the recommended treatment will be effective. 4. 2 of the above, or then 5, all of the above. And it is 2 of the above. We'll see that the assurance that the recommended treatment will be effective is actually not part of it, but we will have to discuss the reasonable aspects of that. So here are your components of informed. So here are your components of informed consent regarding how to go about getting it. The first one, as we saw in the previous aspect, is the diagnosis or finding of the physical examination as part of the patient's involvement in the treatment. They should be informed of what has been found with their physical examination, and that what you believe to be the diagnosis or the overall problem. From there, you go on and provide a recommendation of whatever treatment procedures and rehabilitation plan that is occurring. And then the prognosis being the fancy word for believed outcome. Right? And so what is the believed outcome if the recommended treatment is administered or the rehabilitation plan is completed? Understanding that we have goals associated with that, and each treatment is designed to reach those goals. But what those goals are may vary from the standpoint that not all injuries are the same. There is a distinct possibility that even with treatment that there may not be a good outcome with certain conditions. For example, if you're trying to do a non-operative treatment for a meniscus tear, we understand that with a meniscus tear, the limited blood supply, especially to that white zone on the innermost component of the meniscus, doesn't heal very well. And so our plan may simply be symptom management, trying to control swelling, pain, whatever, but we're not going to address the underlying condition of a torn meniscus without some sort of surgical intervention. So the prognosis for that would still be a good prognosis for the ability to maybe return to sport or activity. But on the same note, we should be honest with the limitations associated then with the underlying cause, that the prognosis for actual healing is not good. Next, you move on to the risks and benefits of the recommended treatment. This is oftentimes the components of the contraindications, precautions, different things like that. And there are always risks associated with treatments, and so those should be explained each and every time. And with that, reasonable alternatives for the proposed treatment, understanding that, hey, we may believe and want to do one thing, but there are always other alternatives. Somebody else might do something different. For example, you could substitute like a warm whirlpool for a hot pack or something like that, or all sorts of different treatment alternatives that could be discussed. And then the last component, which is probably the hardest to accompany, because it just is not easy for medical professionals to believe that people may not want to do anything, like they have a right to not do rehab. So with that, because the last one was the prognosis if you do nothing. This becomes obviously much more involved with higher level decisions, like surgeries, more invasive aspects, because the risks associated with our therapeutic modality treatments are relatively low. But when you get into surgical components or whatever, and you're signing those informed consent forms, when they're actually... Next component worth talking a little bit about that is nothing new is simply patient confidentiality, understanding that everything that we do here is associated as confidential records, either protected by HIPAA or FERPA, regarding those different components. And the big component with that, or as far as the difference, is whether or not you're billing electronically for services. And if you're covered under HIPAA, you'll absolutely know it, from the standpoint that it's required to have HIPAA compliance officers, all sorts of different things. Most athletic trainers working in like collegiate or high school environments are actually more covered by the FERPA, where each of these are educational records. And including medical files that the schools have. And so it's still a medical record, and it's still private information. The law requiring compliance is just a little bit different. So negligence, again, we'll cover a lot more of this when we get to administration class, but just a little introduction so you can have heard it before. Negligence is simply providing care that falls below that minimally accepted standard. That minimally accepted standard is what we were talking about with the position statements, as often defined by, or the position statement often define that minimally accepted standard. And so also with that, you have everything from your state practice acts, best practice, and then your policies and procedures manual. We'll end with a discussion on policies and procedures manual, but that's the main go-to aspect that should have just about everything that you would need in there, and then that can be reviewed by legal counsel. So negligence, as far as things go through, some definition components. You can be negligent in delivery of treatment in one of two ways. Either an omission, which means you failed to do something that you needed to, oftentimes either failing to get informed consent, or in emergency situations failing to do any intervention, much less common than the act of commission, from the standpoint that you do something that you weren't supposed to. Either you did it inappropriately, you had the ultrasound modality too high, and you burnt the patient, that would be, in this case, I guess, a victim. Or, the reason for the contraindications, you did a modality on somebody that shouldn't have. You can also have negligent care facilities. This goes along the lines of making sure that our systems are safe, and the calibrations associated with therapeutic equipment. Right? If these lapse, then we have problems, and usually they suggest that at least yearly, if not more often as recommended by the manufacturer. But if there's not a manufacturer recommendation, usually yearly is appropriate, and that document needs to be kept on file. And you usually see stickers associated with the date of the last calibration right on the modality themselves. Another question here, what part of the FDA's minimal requirements for device labeling describes conditions where the risk of use outweighs the anticipated benefits? Contraindications, warnings, boxed warnings, or precautions? And it is the contraindications there. That's what makes it a contraindication, that the risks outweigh any anticipated benefits, so there's no reason to do that intervention with that patient. Next question here, what best defines negligent behavior when a person acts on a situation but does so at a level different than a reasonable and prudent person would? A, act of omission, B, act of commission, C, tort, or D, fraud? So the FDA now comes into play, and those different warnings that you saw before in the contraindications question shows the FDA's oversight of therapeutic modalities. With that goes through, and each one of those were specific components associated with different treatments or different rules with contraindications, warnings, box warnings, and precautions. And we talked about the contraindications being the risk outweighs the potential benefits. Precautions being the idea that we have risks, but the anticipated benefits still outweigh those, so we just do it precautionary. And then warnings and box warnings are manufacturer required things to provide. On their warnings are lower level All right, so if we go back and think about the question with the contraindications, we see that the FDA provides oversight for therapeutic modalities as far as that goes. And so each one of those potential answers there are components of the oversight of the FDA, where contraindications we saw was where the risk of use outweighs the anticipated benefits. And precautions then are the opposite of that, or the switched of that, where there are potential risks. However, the potential benefits outweigh those risks, so we apply the therapeutic modality or the intervention just in a more cautious way to try to minimize those risks. Warnings and box warnings now are FDA oversight components that are manufacturer based as far as labeling. Warnings are a little bit lower as far as severity. So next question here. According to the FDA medical device classification system, what classification would a device get if presented a great risk to the patient? 1, 2, 3, or 4? And this is class 3, not that it's particularly important that you memorize the rules associated with each class of therapeutic modalities or device, but understanding that these do exist, and as the number increases, so does the potential risk to the patient. Which develops safety standards and regulations to prevent work-related injuries and illnesses? A, the Food and Drug Administration, FDA. B, Health Insurance Portability and Accountability Act, HIPAA. C, the American Hospital Association. Or D, Occupational Safety and Health Administration. Okay, next question here. Which develops safety standards and regulations to prevent work-related injuries and illnesses? A, the FDA. B, HIPAA. C, the AHA. Or the key component to that last question was the idea here of work-related injuries and illnesses. OSHA is a federal organization that provides the standards for workplace safety in any environment where employees have potential risks. We see this with the universal precautions, the necessary for exposure plan. So whereas the FDA talks mainly about the safety of the patient, OSHA now is more about the safety of the employee. Okay, another question. A failure to maintain accurate, legible medical records may result in what charge? A, ordinary negligence. B, professional negligence. C, ordinary and professional negligence. D, neither ordinary nor professional negligence. And it's professional negligence. What we see here with the importance of medical documentation for the legal components regarding the administrative considerations associated with our treatment planning, we have a professional obligation to maintain accurate and legible medical records. The idea that we have to have documented what was occurring so that way it can be independently reviewed if necessary. So there's really no excuse for not having medical records. Now, that being said, athletic trainers generally suck at record keeping. You can just think in the athletic training room, the amount of procedures that are done on a routine basis with absolutely no documentation. And that's really just done for expediency, as well as the components of the relatively low risk associated with the vast majority of our treatments that we are doing. The more controlled or the more risk associated with the treatment, the more important the documentation comes. But if somebody was to be burned, like with an ultrasound or a hot pack or whatever, and they were to sue, the lack of records would become very problematic. And the idea that, it says if it wasn't documented, it wasn't done, goes primarily from the standpoint of the safety components. With informed consent, if you don't document getting informed consent, then you don't have it. Now, in most athletic training situations, as well as different athletic training rooms, you get a blanket informed consent component that usually says by entering or signing into treatment, I'm giving consent for the overall treatment, which is usually good enough. but is really not at the legal standard that we would expect. So we talk about medical documentation, and we start off every time with the idea that medical documentation is a requirement associated with professional standards, and that is true. But there's a bigger reason that documentation should be kept, and I really call this, the what if you got hit by a bus, syndrome. The idea that in athletic training we don't document nearly as much because we're always there and we're always the one providing the treatment, so we remember and everything that goes through. But what if the clinician was not there, they got hit by a bus? How would that treatment plan be communicated to other potential members? And so when we get into medical documentation, it's not just simply a CYA situation. It's also an important component of treatment planning, from the standpoint that our treatment plan needs to be written down so that we can monitor its effectiveness, as well as it can be communicated across healthcare providers, right? As well as the patient or different family members, if they so desire to get those documentation. The idea that the best treatment plan is only as good as the overall ability of somebody to remember it. And so we talked in the past about the evaluation associated with good treatment planning and making sure that we're making changes associated with that. We won't be able to do that if we don't have accurate documentation to do so. And that leads right into the idea that we need to document the day's treatment as well as the overall progress, so that we can measure as well as see the progress being made. The recommendation that each treatment should describe the date, time, individual providing the care, the pathology being treated, the intervention, and then as well as the parameters. And then finally, a pre and post interview that can be included in our overall documentation, that includes now not only what was done, but the effectiveness associated with that. And we'll see some ways that we can do that beyond just asking here in a second. Keep in mind that these are legal records associated with that, especially considering the overall nature of working in a either healthcare setting or an educational setting. All of those different documents that are created become legal records and part of the person's record. You can see the components associated with government and government regulations of records in the present day components associated with the election and everything from General Petraeus to Hillary Clinton, associated with each one of those things being created, are now legal records and governmental properties. It's no different when we get into these sorts of situations. All right, so if there were any litigation that were to occur, these documents may be admitted as evidence, and so they need to be done in a standardized way. Well, and this is something that needs to be addressed in the program as far as our overall understanding of medical documentation, and get you guys doing some more of that earlier on. Right now it's mainly in the administration class. We'll talk more about that there. But I encourage you to ask your preceptors everywhere you go through what sort of documentation requirements they have and how they go about meeting those. If you haven't looked at the injury zone software that the athletic training room uses, ask to just kind of see that and see what goes in that, so you can understand this all a little bit better. So different types of medical records and are listed here. So let's go with the what medical record provides an ongoing record of the patient's intervention plan. A, the treatment record. B, the prescription record. C, the injury report. Or D, the medical history. And it's the treatment record. That's probably a gimme question there, but you can see now the different components that should be included within your documentation. A treatment record, any record of prescription or even over-the-counter medications. Each situation should have an injury report, and then a medical history. This is usually done with a pre-participation physical examination. So as promised, we're making our way now to the policies and procedures manual and the important components associated with that. And this is facility-based. Some policies and procedures manuals may include multiple facilities and multiple situations, such as the different athletic training rooms and different places that the Sanford employees work at. They're still covered under the same policies and procedures manual for the sports medicine team associated with that. But when we look at the facilities, we're talking primarily trying to minimize or eliminate any potential hazards that could occur, as well as being compliant with all ADA regulations for any patients or clinicians with disabilities. The big components that we'll see here as we go through are the hydrotherapy room and treatment areas, and then the plumbing and electrical systems associated with that. So one of the big ones here then we go through is the electrical system and the component of ground fault interrupters or ground fault circuit interrupters, GFIs or GFCIs. And what a GFI is a component of the electrical system. It's a specialized outlet. It's in any place that electricity and water might meet, in which there's a fail-safe built into the component that if there is a surge in electricity that might be included in some sort of potential accident, it trips the power and cuts the power associated with that. Now, each electrical stimulator or modality must be in a ground fault interrupter surge protected circuit. Now, you don't need an individual outlet for each component. One GFI outlet protects the entire circuit with that, but you should check the GFIs and make sure that you know that it's a component with that. And so as part of your regular treatment setup, you should check the GFI, make sure it's working. Now, how do you know if the modality is on a GFI? Well, the GFI is pretty simple from the standpoint that these are the outlets that have the red and black buttons associated with them. And if you press the red button, I believe, I'm blanking a little bit. If you press the red button, it'll pop the circuit, and whatever is connected to that circuit will then lose power. You have to reset the GFI by pressing in and holding, I believe, the black button till that goes through. So you should check the GFIs regularly as part of your treatment. And if you were doing, say, a mock assessment or with the BOC, one of the things that you would do as part of your pre-application components would be check the electrical system with the GFI. One thing that we probably should be adding to your checkoffs as you go through is a GFI check. So the treatment area needs to be effective. One of the components that again doesn't always get into components is the idea that treatments and treatment areas need to be compliant with ADA, that so that you can have adjustable tables for different heights or whatever. But usually most of them are about 30 inches high. Split leg tables are helpful. What these basically are is the bottom component can be elevated and propped up, which we usually do with those wedges, but these can be built into the table. Shortwave diathermy is something that we'll talk about later. It's a very effective deep heating modality, but because you are actually delivering very high frequency sound energy in the air, the treatment area has to be specially arranged for that with no metal associated with that, because it has a very high dispersion rate and it can heat up that metal, potentially causing problems. And so you have to make sure that your treatment area is conducive for that. Same sort of thing when you get into high-level lasers or light therapy units. The idea that those can be transmitted beyond simply the individual treatment area. So you need to make sure that either you have glasses for everybody in the room, or that the treatment is given in an area where other people are not present, and then the glasses are worn for those there. So one of these questions that you guys should all get, because you have checked off on your Whirlpool components, but just go ahead and ask it anyway. Where is the ideal location for the on-off switch for a Whirlpool motor? A, within reach of the patient in the tub. B, out of reach of the patient in the tub. C, mounted on top of the tub's motor. D, it does not matter where the on-off switch is located. Right, and as you guys have all checked off on said, you're not supposed to turn the motor on or off when they're in the Whirlpool, because during those times is the biggest time for a possible short circuit. The GFI should catch it, but again, even then, the momentarily shock anything would be problematic. So ideally, that switch would be in an area that the individual could not reach, thereby eliminating the potential problem. Now, I've never seen that actually done in that way, so it's one of those reality versus optimal situations. So recommendations here now for the hydrotherapy area itself. We talked there on that last one about the components, switches not being in reach of the people within the tub. But the hydrotherapy area itself should be in full view of the staff. for any potential problems associated with that. This is a bigger deal. In a lot of athletic training rooms, we have a pretty decent setup for that, where the hydrotherapy room in all reality is kind of too far out in the middle of everything. But hydrotherapy rooms are often tucked back in a corner or back in another room associated with that, and it doesn't provide good visibility with that. Because of the amount of water associated with that, we have the potential for bacterial, fungal, and virus growth, and so ventilation and humidity become important components to monitor. You can see the recommendations listed there. As far as 40 to 50% humidity and air recycled 8 to 10 times per hour, and these are sorts of components excuse me, that your HVAC people on your campus would be able to know and be able to monitor and provide changes if need be. All right, whirlpool temperature gauges need to be present and calibrated annually. As far as that goes, it's the calibration's pretty simple. You take a more standardized thermometer, and you just check the temperature between the two and make sure it's within an acceptable range. And then the big component there becomes this component of non-slip surfaces with being sloped towards one or more floor drains. The idea that no matter what you do, water is going to get out of the whirlpools. And so we need a way to make sure that we minimize any potential slipping that occurs, and you do that with a non-slip surface as well as a way to eliminate the water from the surface. All right, next question. All therapeutic equipment must be inspected and calibrated by a qualified technician at least yearly, weekly, monthly, or twice a year. We've talked about this a couple of times, and the answer is yearly. The only exception to this would be if the manufacturer recommends calibration more regularly than the yearly calibration. This really includes the vast majority of therapeutic equipment, including hydrocolators and the like. So looking at, the product maintenance and all those sorts of different things, you guys talked about this during your checkoffs and all that, as far as the regular inspection for defects, hazards, and periodic cleaning, with that professional calibration then being annually, if not sooner. Needs to be documented on the unit with those stickers, as well as kept as we go through. All right. If there is any defect within the cord, or if we have constant tripping of the GFI, then it needs to be unplugged, labeled as being inoperative, and removed from the treatment area until it can be serviced by. To the end here with the policies and procedures manual. This is part of the treatment planning, from the component of it is the treatment plan before the plan. This is often done in a collaborative manner and then reviewed by legal counsel, from the standpoint that this becomes now the standard operating procedures. This includes everything from the facility scope of service, as far as what is and is not going to be done within that facility, and then how these are going to be included. This also includes then the job descriptions and the organizational charts, and that becomes important from the standpoint of the acts of omission, the standpoint, what people shouldn't be doing, as well as the or don't need to be doing as part of their job, as well as commissions, what they should not be doing. The job description provides that component and the information needed to gain that as we go forward with such. Then you also have your medical documentation procedures, as well as any examples of how each of those should be performed and how they're going to be stored. Shorthand included in an appendix as far as different things that might go through. And then finally, all of those different regulations by the government need to be documented regarding how these can be instituted and met in that facility. So this is the end of the administrative considerations talk with that. There will be one essay question on the administrative considerations component, but it'll be more general in nature, and I'll give you some of the guides as far as that different things go, as far as what's most important. But you can see on your study guide the different components and different sample questions as it goes through. Remember, we're talking about this primarily from the standpoint of treatment planning. So what sort of things are we going to include or what sort of things do we need to know as part of that overall treatment plan is our component for this one.
So when we talk about modality application and the specifics around how to go about applying the modality, we'll be going through the modalities as a overall group, but then some specifics. But you need to remember that for each modality application, you need to go through each of these specific steps. And so I really want to challenge you to practice this within your own mind every time you're giving modalities, even though you may not and probably will not do this in the clinic every single time. But this is the official textbook approach, and the approach I would like you to use for class and our decision-making simulations. And so just like everything else, a treatment begins with hand hygiene and a greeting and patient identification. Remember, we need to make sure that we are keeping our patient safety as our first priority, and that includes both hand hygiene and then making sure we're applying the right treatment to the right patient. So you start by either introducing yourself or you have your ID available so they know who you are, and you ask them to repeat their name and date of birth to make sure that you have that. You're then going to get informed consent as well as check for indications. And so informed consent is their understanding of the treatment that they are going to receive. And so in order to do that, you need to explain to them what the diagnosis or working diagnosis is that you're working on, the treatment that you're going to give them, the prognosis of their course with the treatment, any risks or benefits from the treatment, alternatives to the treatment so that they have the ability to think about possibly doing a separate treatment, and then the prognosis without the treatment, so how you would expect this condition to progress if they did not receive the treatment. And so it's important that they have an idea of what treatment they are going to receive early on as far as the risks, and then they give their consent to receive the treatment. You also then at that same point in time check with the indications, and what an indication is indications, as the definition is right there, describe the intended use and specific types of conditions that warrant the use of this device. So each modality and more class of modality opposed to each specific modality has its own list of indications. So you would want to make sure during this time that the modality or treatment that you are going to give the patient is actually indicated in this condition. The next step is the contraindications and precautions. And so this is slightly confusing with this in reality, because there isn't specific lists for contraindications and precautions that are generally accepted. You'll see one textbook lists something as a contraindication, one thing lists something as a precaution, and then you'll see things that are listed as contraindications that should be precautions. So I'll give you more of the textbook definition, but realize during this time you're looking for any potential things or unique things with your current patient that would make the treatment more dangerous. And so a contraindication by definition is when the risks of use outweigh the anticipated benefits. So based on strict definition, a contraindication would mean that you would not apply that modality to this patient in any circumstances. Where a precaution then is simply the user needs to use special care. Now, in reality, you need to know the contraindications, but we're not going to see lots of contraindications. More likely, we will see precautions, and where we need to give additional consideration to safety to use the modality effectively. After you've checked for contraindications and precautions, it's important that you do an overall safety check or check safety considerations. This includes product maintenance, checking for things like frayed wires or anything out of the ordinary, as well as checking to make sure that the modality has been calibrated in an appropriate amount of time, usually within the last year. And then for all electrical modalities, you need to make sure that the modality is connected to a ground fault circuit interrupter. And there's more about that in class, but basically this is a special type of circuit. So if you've seen those outlets with the little red and black buttons there, that's a ground fault circuit interrupter, or a GFCI or GFI. And you see these in your bathrooms, right? And the idea is if that somehow there's an extra ground, or somehow the electricity is flowing outside of that, and there's a surge, it pops the circuit and disrupts the electricity. So each electrical outlet that you plug into does not need to be a GFI. There only needs to be one GFI per circuit. And so, like, if you have an electrical outlet that's not working, you can always check to make sure that a GFI somewhere else in the nearby area hasn't popped. But basically what you need, if you don't know that it's already on a GFI, what you would do is you would find the GFI, make sure it's working, and you would press the test button, and that should turn off the modality. You can then reset it, and it would go on. In that case, you are connected to a proper GFI, and so you can continue. But for all electrical treatments, it's important that you're plugged into a GFI in case there is a surge of electricity for some reason. After you've done your safety considerations, next we're going to start preparing for the modality application. And so the first thing that's going to do is you need to get baseline measurements. As we've discussed previously, with this idea of using modalities for specific goals and to accomplish specific tasks, we need to know whether or not we are in fact accomplishing those. And so if you go back to looking at and thinking about the patient-centered care and the ICF models and different aspects like that, it's important then that we know that what we are doing is accomplishing our goals. And so in order to do that, we've got to make sure we are collecting our baseline measurements. And so these can be either clinician-derived measurements, things like um, girth measurements for swelling, volumetric measurements for swelling, right, where you could have them place their foot in a bucket, and so the old idea with displacement, and you have the hole and you can measure the amount of displacement that occurs, so that way you can measure how swollen it is. Range of motion assessments, whatever our goal is, we can get a measurement on that. We can also get patient-oriented measures, things like pain scales, levels of functions, and then finally, over time, we get that health-related quality of life. So these baseline measurements could be specific for one modality treatment, or they could be more for long-term use, but we need to make sure we are collecting data on the effectiveness now of our treatments. The seventh step listed there is the modality setup, and so these will be listed specifically for each modality as far as how you go setting it up, how many channels you'll be using for electrical modalities, everything from how to tie an ice bag would be in this modality setup. So things that you're going to get ready for the patient or for the modality aspect. And this could be pre-set up if you know that they're occurring. It doesn't have to occur necessarily in this order, but this order works fairly well for moving through a treatment procedure. So when we talk about So after you have the modality set up and ready to go, the next thing you need to do is position and prepare the patient. And so this is things like draping that we talked about, as far as having appropriate modesty, with that only exposing the amount of skin that we need to for treatment. We also need to make sure that the patient is relatively comfortable. Oftentimes, one of the treatments that we are doing, or goals, is to reduce pain. And so obviously, we want to put them in a position of maximal comfort. So one example of that, is if you're, doing like a neck treatment, maybe put them prone with a prone pillow opposed to seated, and so that way their neck muscles can relax a little bit more. We also need to position and prepare the patient for any secondary treatments that we might be doing, whether or not that's something as simple as adding elevation to our treatment. So if we're doing an edema reduction treatment, we would want to position them in a way that would also allow for elevation to help in that edema reduction. Or as we'll see in like ultrasound, there's a relatively short stretching window after heating up, so we would want to position them in a position that we could immediately move from the modality treatment, the ultrasound treatment, to a stretch quickly. So we need to be thinking about that when we initially position the patient, whether or not that's putting them in a position where we can immediately go into a stretch afterwards, or using a table or having the device ready next to them. So an example of that might be like if we're doing a continuous ultrasound to heat up the calf muscle, we would want to put them probably in a prone position with their foot already off the edge of the table. So as soon as we're done ultrasounding that calf muscle, we could go into that stretch. Or if we were going to do a more aggressive stretch, we would already have the slant board right there at the end of the table. So as soon as we're done doing the ultrasound, they could go and begin that stretching position. At that same note, you have to make sure that you're taking into consideration your own health and safety. And the biggest one with this, besides the obvious safety consideration sort of things, is your own positioning for repeated treatments. And so we'll look at and talk about within um, within modalities practice sessions, how you can position yourself so you're not bent over constantly, whether that's seated and how to adjust the stools or different components. So that way you can do the treatments back to back to back, or more importantly, you can continue to do the treatments right now. Is a relatively young, healthy population of athletic training students. It's a lot easier for you to do these treatments in awkward positions. But we should be also um, making sure that we're also safe and able to perform these treatments, even if we weren't as young and healthy. The next step is patient education. And so this is different than the initial informed consent. This is now specific to within the treatment education, whereas informed consent is more about um, before and specifically after the treatment, having them choose whether or not they want the treatment based on what sort of outcomes they'd have. This is about what's going to occur during the treatment. And so before you would go and just immediately start treating somebody for something, you want to make sure that they know what they're going to be experiencing, as well as what they shouldn't be experiencing, and whatever emergency stop situations there would be. So like for electrical stimulation, it's often important for us to get feedback on the intensity of that treatment, right? So, you explain to them if they've never had electrical stimulation that they might start feeling some of that, tingling sensations, and that would increase. We want that to be as strong as possible, but still comfortable. If it's painful, we need to turn it down. Or if we start seeing the muscle contraction, we might want to also turn that down, right? And so understanding that, and that same note, for a lot of these electrical stimulation treatments or any really modalities, all of those machines have the ability and should actually really have hooked up at all times an emergency stop button that you can hand to the patient. And so like if you have somebody set up on a quite elaborate setup and they would not be able to reach over and hit the emergency stop button on the machine, you would hand them this emergency stop button as well. And we'll show you that as we go forward. But you have that emergency stop button, or at least at minimum, show them how to stop the machine, themselves using the stop button on the machine. This isn't particularly important if you're doing treatments where you're not in the room. So if you were to like hook them up in the back athletic training room or in a private treatment room, and then you were to leave the room, they need to be able to stop that treatment immediately, opposed to just yelling and screaming for you to come through. After that, you're obviously going to apply the treatment, and we'll talk a lot about this as far as picking the right settings, as well as the technique for applying that. So that's what clinical class spends a lot of time with. And most of the time, you guys are fairly good at that component with there, because that's what you do every day. Afterwards, we need to, if we have baseline measurements, we also need post-treatment measurements. And so that is both collecting any immediate or delayed outcomes depending on the goal, right? If we're trying to decrease pain, we need to assess that pain both immediately before and after the treatment. But at that same note, some of that post-treatment measurements is consistent with that patient values component. How did the patient feel about that treatment? Did they feel like it was helpful? Did they feel like it, were they comfortable? Those sorts of things need to be assessed as well. After that, you're going to clean up the modality as far as taking it off of them or different components with that. That may occur before the post-treatment measurements. It may occur after. Again, order isn't necessarily as important for that one. And then finally, you're going to do your documentation. You need to document every treatment that you do as far as what the settings were. So you can think of this as like your own little method section. So somebody else should be able to repeat your treatment. Um, if you needed to repeat that treatment tomorrow, so if somebody came in, you just said, hey, do the same thing we did yesterday, they should be able to look that up. And at that same note, from a legal standpoint, you need to document it so that you know exactly what was done. With that. And then obviously we've talked about outcomes and billing documentation previously with those outcome measures and CPT codes with that. And so if you don't remember what those are, go back and look at those presentations as well. And then we obviously end with hand hygiene as well, that whole scrub in, scrub out.